Good afternoon, everybody. Myself, Dr. Amol Akhade. I hope I am audible as well as my slides are visible. Can you see my slides?
Yes.
You can see the slides, right? Are my slides visible?
Yes, sir. Yes, sir.
Okay. So basically today we are going to discuss about immunotherapy for cancer. Myself, Dr. Amol Akhade, I am the medical oncologist and hemato-oncologist at Reliance Hospital. So in 2020, we have two pandemics. And one is, of course, COVID-19. And as of today, I think we are almost touching 19 lakhs cases in all over country. And even though our case fatality ratio is around 2.7, which is much less as compared to the Western world, our absolute numbers are significantly high. And as we all know that Reliance Hospital is at the forefront in taking care of the COVID-19 cases. And we have an excellent team here to take care of COVID-19 patients, both moderate as well as severe. But now, fortunately, the pandemic is slowly coming down. Now we are into the unlock phase, and unlock 3 will be starting from tomorrow, and hopefully more and more activity will start, and we hope that the second wave doesn't reach us by December. But there is another pandemic which is along with this, and that is, of course, slides are stuck. That is the problem with the webinar, that your slides may get stuck. Wait. Just a minute, I need it back up. Are the slides stuck there? The slides are not moving.
Just click here.
Okay. Sorry, this thing. So basically, the next pandemic that we have is of the webinars. And nowadays, there are so many webinars go on that this is the, I don't know whether you would appreciate this. If you see the graph, that as the number of corona cases are going up, the number of webinars also are going up, use of WhatsApp is also going up. But at the same time, unfortunately, doctors' earnings are going down and knowledge is remaining static. So it is our humble attempt to have an interaction with as much family physicians as possible, so as to have some interaction with the doctors and some understanding about the current topic of immunotherapy. So basically, we will be discussing three things. One is evolution of cancer chemotherapy, second is targeted therapy, and the last part is immunotherapy. So as you all may be knowing that the chemotherapy started somewhere in 1946. Dr. Sidney Farber was the first person to use methotrexate, which is an antifolate drug for acute lymphoblastic leukemia. He discovered it by default. He was studying the folic acid analogs, and he found that if you give folic acid supplements, cancer cells grow. Then he thought, if I can block folic acid, maybe I can control the growth of cancer cells, and that is how he produced methotrexate, the antifolate drug, and it was the first drug used for any cancer in the world, and it was used for acute lymphoblastic leukemia, and it is still the part of the regimen. Then for the solid tumors, choriocarcinoma, methotrexate was used in 1956. And again, till date, almost 70-80 years, still date, methotrexate is used for choriocarcinoma. Then more and more drugs started getting discovered, and then comes concept of combination chemotherapy, what is called as ABVD, adriamycin, bleomycin, vinblastine, and dacarbazine, which is in combination chemotherapy for Hodgkin's lymphoma, and it is still being used for Hodgkin's. Then people started using it for other cancers like breast cancer. The first regimen that came was CMF, cyclophosphamide, methotrexate, and 5-fluorouracil. This was way back in 1975. And then slowly the drug called as paclitaxel, which came around 1990s. And now this is being used at random for most of the solid tumors, paclitaxel, carboplatin, gemcitabine. So these are the progress of the conventional chemotherapy, right from 1945 around that time when methotrexate came, and now paclitaxel, gemcitabine, doxorubicin, carboplatin, various drugs are available. But problem with these chemotherapy drugs is that unfortunately they act blindly, which means they act on cancer cells as well as on the surrounding cells. So they have a lot of side effects. And because of this blind approach, patients end up getting a lot of side effects, and that leads to what is called as chemophobia. That means if you talk as a physician to any patient that you have cancer and you have to take chemotherapy, probably they are more afraid of the chemotherapy than the cancer, because you have a lot of side effects, hair loss, sometimes you may have a lot of nausea, vomiting. So there is a lot of chemophobia among the patients, and that is why over the years people were trying to find out newer drugs which will act only on cancer but not on the surrounding cells. Why the alopecia occurs? Because the conventional chemotherapy drugs will act on the hair follicles. Why mucositis or diarrhea occurs? Because the conventional chemotherapy drugs will act on the GI tract. So they have a lot of other side effects, and that is why you have what is called as chemophobia, and a lot of people are not ready to take chemotherapy. So to improve that, there is a new generation drugs came called as targeted therapy. So these are the drugs which have come since almost 2000 onwards. In last 20 years, there are a lot of targeted drugs have come. And as the name suggests, they act only on cancer cells and they avoid normal cells. So that is how the targeted therapy works. And in the simple way, previously, suppose you have one cancer patient of say lung cancer, then all lung cancer used to be treated in a similar manner. But now what we try to do is we get a molecular and clinical profile of the patient and the disease, and then based upon that we subdivide those say lung cancer patient to three types, and then for individual type we have individual drugs. If you see this diagram, it is not entirely black nowadays. We have patients which may be red, which may have blue, which may be green, and then for individual characteristic we have individual drugs. And that is how the targeted therapy has evolved. And as I told you, the example for lung cancer, this is a simple slide just to tell you that lung cancer has so many subtypes. If you see the slide, almost 25% lung cancer have KRAS mutations, 17% have EGFR mutation, 8% have ALK mutation. Then there are certain mutations that are present on 1 to 2%. But what is important is that on all of these mutations, there is a targeted medicine available. That means almost 64% of lung cancers will have some or the other targeted mutation present, and those targeted mutations can be targeted for a treatment. So as I've shown in the previous slide, that it is not entirely black that all three patients to be treated the same manner of lung cancer. No, we will find out which one has KRAS mutation, which one has EGFR mutation, and according to the mutation we'll treat them. So that is the era of targeted therapy. So now there are so many targets and so many drugs available. Now some of these drugs are quite blockbuster drugs. You must have heard them. What is called as trastuzumab, which is the drug used in breast cancer against HER2 receptors. Then there is bevacizumab, which is used against VEGF receptors, which is used predominantly in colon cancer. Then there is drug called as cetuximab and panitumumab. They are used in colon cancer and head and neck cancers. Then imatinib, which acts on tyrosine kinase domains. Imatinib is a wonder drug for what is called as chronic myeloid leukemia. Up to 1997, CML was very difficult disease to treat. People used to use hydroxyurea, people used to use bone marrow transplants. But after 1997, when the imatinib came, the treatment of CML has become very easy. It is a simple tablet you take and you take it lifelong. The way hypertension patient takes one tablet lifelong, diabetes patient takes tablet lifelong, CML patient, chronic myeloid leukemia, which is a blood cancer type, those patients also take tablet lifelong. So targeted therapy, just to give some examples, sorafenib is for liver cancer. So these are the targeted therapy drugs which are revolutionized the treatment of cancer, especially the chemotherapy part in last 20 years. And now the next step is immunotherapy. So what is immunotherapy? It is, say, for a simple way to explain it, in our in body there are almost 1 billion cells, and most of these 1 billion cells are dividing, like our skin cells, our mucous membrane cells, or most of our cells are in dividing phase. Now, when you have, suppose you imagine a large factory where there is 1 lakh machines which are working and they are doing production. When you have so much of turnover, it is bound to have errors. The same way in our body also errors occur. Not every cell will divide the way it is supposed to divide. Now, generally in a factory, suppose the production of few products is not good, that particular product is discarded. We don't want that product to go into the market. The same way, the body don't want dysfunctional cells to go further. So generally, those dysfunctional cells are removed by the body. But some of those dysfunctional cells will escape, and they will escape the immune system of our body. The removal of dysfunctional cell is done by immune system. Now some of the cells become smart, they escape the immune system, and these are the cells which become cancerous. So in a nutshell, you, me, everybody has potential cancer cells in our body right now also. But our body is, our immune system is able to check those cells and throw them out at the same time. And that is why it is preventing from them becoming cancerous. But unfortunately, some patients, some people, this particular checked system is non-functional. And then those cells escape the checkpoints and become cancerous. So the immunotherapy concept basically is to enhance the immunity of the body in such a way that that particular escape of the dysfunctional cell does not occur, and we nip them in the bud and take them out at the earliest. Now, this entire concept was brought forward with these two gentlemen, Dr. James P. Allison and Dr. Tasuku Honjo. One is a Japanese scientist, and another is, of course, in America, in MD Anderson. Both the gentlemen are alive. Both got the Nobel Prize in 2018 for physiology and medicine for the discovery of the immune system controlling cancer. They have done the pioneer basic work from 1990s, and because of their work in the last 20 years, we have got newer molecules which now we use as an immunotherapy. So we owe today's entire talk and the drugs that are come to these two gentlemen, James Allison and Takusu Honjo. Now, as I said, what is immunotherapy? It is a simple concept that it is a type of cancer treatment that boosts body's natural defense to fight the cancers. It uses substances made by the body or in a laboratory to improve or restore immune system function. So what are those checkpoints? As I said, whenever there are abnormal cells in our body, you must have heard T cells and B cells. These are the immune system cells. B cells are required for antibody production. T cells are required for killing cells like virus or parasites or abnormal cells like cancer cells. In COVID-19 also, in a vaccine formation, they are trying to target the T cell immunity so that the virus can be early targeted and eliminated from the body. So in same way, in cancer cells also, there are two distinct pathways called as PD1, PDL1. PD stands for programmed death 1, and its ligand called as programmed death ligand 1, and CTLA4, cytotoxic T lymphocyte antigen 4. So these are the two pathways. Both these pathways were discovered by Dr. Allison and Dr. Takusu Honjo, as I've shown in the previous slide, and they got the Nobel Prize for the discovery of these two pathways. These are critical to the immune system's ability to control cancer growth. These pathways are often called as immune checkpoints. Many cancers use this pathway to escape the immune system. Now, immune system responds to the cancer by blocking these pathways, with specific antibodies called as immune checkpoint inhibitors. I will explain this in this simple slide. Suppose let us assume that this is the cancer cell and this is a thief. This is a thief and this is police, the antigen presenting cell or the CD8 T cell, which is the police. And the police is trying to catch this thief. But the thief is smart. What it does, it produces what is called as PD2, PDL1 and PDL2 ligands on the tumor cell. So it gives a bribe to the police, that is CD8 cells, and because of this bribe, that means binding of this PDL1 with the PD1 present on the T cell, the function of the T cell is inhibited. This red is showing inhibition. So basically, this CD8 T cell of the body, whenever it goes to try and catch this tumor cell to eliminate it from the body, the tumor cell gives him bribe in the form of PDL1, PDL2, which binds with PD1 of the CD8 cells, and then the CD8 cells function stops. So this particular bribe is blocked by these newer drugs called as immunotherapy drugs. So these drugs will go and bind this particular binding between PDL1 and PD1, and because of this particular binding is blocked, the cancer cell is not able to bribe the T cell. The T cell will recognize this is a foreign cancer cell and it will eliminate it from the body. So that is in a nutshell how the cancer cell escapes the police of our body, that is the T cells of our body, is by bribing them by PDL1, PDL2. That particular bribe is inhibited by these newer drugs, and hence the police has to catch the thief, and then the tumor cells are eliminated from our body. So this is in a nutshell how this works, and there are a lot of new drugs which have come up. Some drugs which blocks this PDL1 inhibitors, some drugs block PD1 inhibitors, some drugs will inhibit CTLA4, and a lot of new drugs have come up, especially in the last 7 to 8 years. These all drugs started first in melanoma. Melanoma is a tumor which is more common in Western population. In Indians, fortunately, because we are dark-skinned people, we get less of melanoma. So for melanoma, all these drugs have proved very, very fruitful and almost curative. And because it started working in melanoma, they started exploring other tumors, including colon cancers or stomach cancer. A lot of other cancers, these drugs are used. And if you see, there is a new army of drugs. Now, if you start pronouncing them, that becomes very difficult. They are called as, jokingly, we have run out of things to name our drugs. It's time to invent some new alphabetic letter. So ipilimumab, nivolumab, all these are tongue twister names. Atezolizumab. So these are the drugs which are available currently, and they are available in India also, not just in Western countries, but in India also. And these are the various cancers against which the drugs can be used. As I said, the most important indication is melanoma. Then there is certain types of colon cancers, but right from lung cancer, kidney cancer, liver cancer, Hodgkin's and non-Hodgkin's lymphoma, bladder cancer, rectal cancer, stomach cancer, you name the cancer of the body and there is a drug available, which are the immunotherapeutic drugs. So what I want to tell you that you should be sensitized that in last 6-7 years, a lot of new drugs have come up for cancer, and they are useful against most of the solid tumors and some type of blood cancers, and they are really wonderful drugs. Now, what about blood cancers? So blood cancer, there is a concept called as chimeric antigen receptor T cell therapy. Now, mind you, the previous drugs were available in India, but CAR T cell therapy or chimeric antigen receptor T cell therapy is not yet present in our country. So what is this T cell therapy? In this, what they do is that it is first of all, it is an individualized therapy. It is not a disease specific, but it is patient specific. You have a patient of blood cancer, you take T cells from that patient's blood, then you expose those T cells to the cancer antigens from that particular patient and train those T cells, and then those trained T cells are introduced into the patient's body, and they will go and destroy the cancer cells. So in simple language, your body's police system is not trained to kill the thief. So you take those police out of your body, you train them, you give them machine guns and put them back in your body, and they will go and kill the cancer cells. So this is how it works. First, we have a patient of blood cancer. You take the T cells out. T cell is the police. You expose them to the newer techniques of the cancer cells and give them a training. And once they are trained, that means they are activated by exposing to the cancer antigen, and they are fully functional. You infuse them back into the patient's body, and then these cells will go inside and will kill the cancer cells. So this is a highly individualized therapy called as CAR T cell therapy. It is not yet available in India. It is used for relapsed blood cancers, extremely costly. This will cost around 5 to 6 crore for 1 or 2 sessions. So it is that costly. But mind you, lot of institutes in our country, especially IIT Mumbai, they are trying to produce our own generic version of this CAR T cell therapy. And if that happens, probably the cost will significantly come down. Maybe in next 4 to 5 years, we may expect that this therapy coming to India and the cost coming down. Another thing is dendritic cell therapy. As I said, we have the police system in our body. One is T cell and another police is dendritic cell. Dendritic cells are also a type of immune controlling cells in our body. Generally, they're not active. But in this particular drug called as Provenge or Supilocil T, they have done the same thing. They have taken those dendritic cells out of the patient's body, and they have trained them with the prostate cancer antigen, and then they have infused them back into the body. And generally, this whole process is done in 48 hours. The product is called as Provenge. Again, this is not yet available in India, but it is approved by US FDA for prostate cancer. For other cancers, it is under investigations. So we talked about 3 new therapies today. One is immune checkpoint inhibitor drugs. Drugs which are called as PD-L1 inhibitors or CTCA4 inhibitors. And these drugs are used for various cancers and they are available in our country. Next 2 things, CAR T cell therapy or dendritic cell therapy, they are not yet available in our country. Maybe in near future, we may get them, provided the cost comes down. So at the end of all these things, you may wonder that what is the cost factor? As I said, nowadays, the newer drugs are only of 3 types. One is exuberantly expensive, rather incredibly expensive, and very expensive. So unfortunately, cost is an issue. The drugs like pembrolizumab or nivolumab, which are the immunotherapy drugs, are costing around 1.5 to 2 lakhs per cycle. And that is why, because ultimately they are manufactured by certain multinational companies, Indian companies not yet manufacturing them, but probably over the years, generics will come. So that is why they say jokingly that this is one of those new miracle drugs. If you can afford it, it's a miracle. So yes, unfortunately, the cost is very high as far as these drugs are concerned. But as we always say that, what is the cost of life? And I'll tell all family members or all my friends or all my colleagues that please take your insurance on time. If you have a medical insurance on time, taken at a younger age, all these drugs are covered by insurance and probably you may not be bothered much about the cost of these drugs. Unfortunately, the coverage of insurance in our country is very less. Hardly 20-30% patient population is covered by insurance. Unlike in the Western countries like in UK or in US, almost 100% insurance coverage is there. So moment this insurance cover will start increasing, more and more patients will start opting for health insurance on time, probably the cost may not be that issue. So last but not the least, please be aware of what is called as cancer QUACKs. cancer, unfortunately, is not a curable disease, and last 100 years research is going on. Still, we are not yet lead to a final solution. And whatever that is not a curable disease, wherever there is science is imperfect, people try to make a perfect commerce out of it, and that is where the so-called cancer quacks come. I don't know whether you have heard about this book called as Holy Cancer: How a Cow Saved My Life. I have read this book. This is about a cow therapy where they apply cow dung and ask people to take gomudra and certain rituals. Somewhere in Valsad it is done, and a lot of people go for this. I am not in favor of this. I have myself went to that place to see how it works, and unfortunately, even though there is no scientific basis, a lot of people try it. This is a book written by an NRI who apparently had a sarcoma which was advanced and got treated, and it is available in the market. I urge all of you to read this so that you come to know that what is being practiced as a cancer therapy in our own surrounding. This is not far off, this is at Valsad. Then another example is about dendritic cell therapy, as I've shown the ProVate. It is not yet available in our country, but if you type in Google dendritic cell therapy India, the first entry comes of some Dr. Jamal Khan and his dendritic cell vaccine, where he has multiple clinics in Mumbai and he sent the blood sample to Noida and he will give the vaccine back in 2 days, charging around 5 to 6 lakhs. So this is all quackery. There is no scientific basis. We as a family physician must encourage our patients not to get into all these things, but to stick to the scientific practice. Scientifically approved immunotherapy is only those drugs which I discussed with you previously, and these drugs are available, these are effective. If cost is not an issue for the patient, one can try them. But at least our job is to prevent patients from going to the quacks and getting into such kind of quackery, which is most of the time practiced on the name of immunotherapy. So at the end of the lecture, if you have any questions and if you wanted to ask, please ask.
Sir, are there any side effects of this immunotherapy?
Yes. See, everything, fortunately or unfortunately, has side effects. Even if you take a simple aspirin, it is going to produce gastritis. But immunotherapy drugs, because they mostly go and stimulate your own immune cells, the conventional side effects in the form of hair loss or nausea, vomiting, diarrhea are less, or in fact non-existing. But at the same time, they have very specific side effects, sometimes like pneumonitis or inflammation in the lungs. Sometimes some patients get some peculiar skin rashes or reactions. So yes, they have certain side effects, but not very difficult to manage, and not like conventional side effects like fall in WBC or fall in platelets or hair loss. So they are much safer than the conventional cytotoxic chemo drugs. Anybody else? Any questions? You still have another 9 minutes. So I think if there are no further questions, we will wind up the session. And if you have any doubts, you can always communicate to me on my email or on Reliance Hospital email. The take-home message was that yes, immunotherapy drugs are available in country, but certain types like CAR T cell or immune vaccines are not yet reached, and we must make sure that our patients don't fall for quackery, which is rampantly being done in our country on the name of immunotherapy. At least we should be able to prevent them from doing that. I think, thank you. In